How are you?
Okay.
Good, good.
Yeah.
I was actually just reading your article on the Times of Israel. The you had posted about it from LinkedIn.
Which one was that?
The response to the negative report on COVID.
Oh, yeah. Yeah, yeah,
Which
yeah.
is interesting.
Yeah.
Aside from what we're going to talk about today, I would love to connect at another time about just health advocacy in Israel. Um,
I'd
I
very much like to do that.
Yeah, well, and it's interesting because I lived, my family is Israeli, and I lived in Israel a long time ago. I was there from 81 to 87. Um, but
Okay.
but it's interesting because I've always thought of healthcare as very different, and even the concept of patient advocacy in Israel is interesting, because
Yeah,
it's
it
already
doesn't,
a
I'm not sure it
politicalized.
exists. Yeah, I don't
Yes,
know if it exists as a concept.
well, yes, correct. I mean, and I can
Yeah.
understand that as well. But
Yeah.
just because the system works so differently, I like for example, just out of curiosity, how are you paid?
How am I paid? So
Yeah.
yeah, I was working independently. So clients were paying me independently. And about 3 years ago, I joined a nonprofit organization that raised money and paid me through their network.
Got it. That's
But
the Shira Lansky.
that's a Sheer Pransky project, right? But
Right.
unfortunately, as of the end of May, there's no funds left to pay me because of Corona. They're so I am now sort of at a crossroads as to where I go again. Do I go back to the I if I go back to doing what I was doing before in terms of health advocacy, then I need to come up with a different model of do I approach like a larger nonprofit like Yad Sarah? I don't know if you're familiar
I
with
am
them,
familiar with
or
that, Sarah. Yeah.
you know, or and try to do it that way, or do I'm sort of exploring right now. I'm actually going to decided to hire a business consultant
Oh,
to
good.
sort of like lead me through, yeah, to see what is feasible, because it's a challenging issue.
Right, but
So
I appreciated some of the things that you wrote and kind of how you were explaining health advocacy, and that you put it out there. I'm relatively new to it. I've been in healthcare 30 years, but as an administrator running practices, definitely on a different perspective. But you kind of put it right out there, this idea that you not only are there to help the patients or the clients, but you're there to make it easier for physicians and for the medical staff. And that's something I
yeah,
talk a lot about as well. Just it's important for the systems to understand that that it's needed. And it's interesting that my whole bent, which is kind of the reason for the conversation, is that I see the U.S. healthcare system as very challenged, right? We
yeah,
spend more per capita, often significantly more, per person on healthcare than most other countries. And I did a quick comparison with Israel, and interestingly, the U.S. spends more than 3 times per person what Israel does on each individual. And yet, most other countries in the world are able to provide healthcare for everybody, right? So,
yeah.
so let's do this. Let's launch right in. I'm already recording because I often find that in these kind of down moments, that's when I can capture little kids. So, why don't we start by would you introduce yourself, and kind of explain a little bit about what you do and how you got there?
Okay. And you can just stop me.
No, that's fine.
However long I can
No
go.
worries.
So my name is Aviva Yoselis, as I am an American, meaning I grew up in the United States, and I moved to Israel as an adult. I worked in the United States in community health, mostly in the low-income Spanish-speaking community in Philadelphia. I don't know where you grew up, or where you're from, but in North Philadelphia.
Philly and Baltimore.
Oh, really? Okay, so you know North Philly. I don't know
Yeah.
if you, it's not a neighborhood that, like, people usually are familiar with in Philly. So I worked there for a few years, and that's sort of where I fell in love with the concept of health promotion and finding out ways to communicate with people and affect health behavior. But when I came to Israel, I realized that if I wanted to continue to work in that field, I really needed a higher degree, because the field of public health for somebody who was a professional and not a physician and or nurse, and who was in public health, didn't really exist. So I went and got a master's degree in public health in Israel at Hebrew University. Yeah. Okay. And therefore discovered my love of statistics and epidemiology, which I hadn't really been introduced to before. And from there, for basically the past 17, 18 years, I've been working in different aspects of public health, whether it be research coordination in community-based applied research, or whether it be a health advocate that I started working in and was certified in the second round of certification. So I became the first board-certified patient advocate outside of North America. And
which is pretty cool.
It is pretty cool. I had to travel to Malta.
Oh, wow, to take the test?
To take the test, because they didn't offer it here. Hopefully, they've now approached me and said, like, we're trying to get it offered here. But
nice.
And my intrepid sister was very generous and flew with me to Malta. Nice. So then I've been exploring that aspect more, working with individuals. So one of my goals of sort of having been in like the academic research world and having been very much in the nonprofit and the individual is trying to bridge the gap between the research that's conducted and the eventual interventions that happen in the field. Because I feel like we have a lot of knowledge about population-based need and what's happening, but when it comes down to how do we implement this in a specific community, I feel like the two groups aren't speaking to one another. So that's kind of like my overarching, dream.
And interestingly, that is, I think, kind of the crux of some of the just probably global challenges in healthcare is the communication issue. And it's on a lot of different levels. So, the reason that I'm doing what I'm doing, and so we do similar work in different countries, and I was particularly interested in what you're doing in Israel because I guess it's a very American thing as well to think, oh, why would this be needed in another country? But I've seen health advocacy in the United States as kind of a product of what I see as of a challenged healthcare system. And we started to say earlier, the U.S. spends more per capita significantly per person, and yet our outcomes are no better and often significantly worse. And we struggle with things like the number one reason for bankruptcy in the United States is medical bills, medical costs. And just to give you some perspective, because I like sharing these numbers because I think that they're mind-blowing. I spend for my family, so I work for myself, so I do not get employer-based insurance, which is what you get in most countries, or most Americans have, is employer-based insurance.
Right.
And so I am using what is known, around the world kind of as Obamacare, which is through the Affordable Care Act. So it means that everybody, in theory, has access. So for that privilege, I pay for my family of four $2,000 a month. Okay? Now, hang on. Oh, it gets much better. So for that $2,000 a month, here's what it covers. Pretty much nothing. Okay? I have a deductible per person, which is $7,500. Okay. Now, there is a family cap. However, we would spend, in theory, over $30,000 out of pocket before anything is covered by our insurance. Now, granted, there's little bits and pieces, some primary care, regular visits are partially covered, but for the most part, our healthcare expenses are out of pocket in addition to the $2,000 a month that we spend. So
Wow.
instead of trying to dissect the U.S. healthcare community, I want to explore what does healthcare look like in other places.
Right.
So, which brings me right to my first question, which is, and this is an American question, because I know the answers more or less elsewhere, but how is healthcare coverage determined in Israel? Who gets covered, who doesn't, and I understand in a lot of places it's tiered, but if you could talk a little bit about that as well.
Sure. It's just interesting to note that your focus from health advocacy really comes from there's a financial aspect to it, and I have that exists where, but for me, health advocacy is much more about being able to feel empowered and receiving the services that are theoretically covered, but often people don't receive for various reasons,
right?
Which we can delve into later. But in terms of Israel, it's very interesting because in 1995, the government decided that it used to be that it was a pay-in system. Everybody paid in X amount, and if you didn't pay, you didn't have coverage. But the government decided every Israeli citizen should be guaranteed a basic, what they call a basket of services that they are guaranteed to receive, whether they are working or are not, whether they are, whatever their age, whatever their ethnicity, etc. So, which means that once you become a citizen, if you work, you pay a tax. There's a health tax, and I don't remember what the percentages are in the United States, how much of your income is going toward taxes. I know there's a state and then there's federal tax, but in Israel, pretty much almost 1/3 of your salary is going to pay, various taxes. That's what provides the sort of social service network that
Right.
you gain. So, which is obviously like a higher cost than people, especially in the United States, they feel like that's not,
Totally.
they don't want to share 1/3 of their salary with the
Right.
government. That being said, that means that you pay the tax if you work. Now, if you don't work, you have to pay a basic tax. And in Israel, there's a caveat. If you're a married woman, then you do not have to pay if you are not working. Whereas if you're a married man and you're not working, you still pay. So that is to, basically make sure that if you're a woman and you want to stay at home with your children, that you're not penalized for that. Because Israel is a very family-based, child-based society. And it's been very interesting to see this become even more evident with Corona, the efforts that the government did to really minimize the spread at the detriment to the economy, and I don't think anybody can disagree with that, but to really save the lives of the older part of the population. Because of that, I think sort of a family-based idea, which is very strong. I mean, you just compare us to Sweden. We have the same population as Sweden. There were, a little bit more than 200 deaths in Israel, and in Sweden had over 2,000 deaths.
Right. Right. Well, and obviously the response was handled almost radically different as well.
Exactly.
Yeah.
Exactly. And I understand, I really understand the Swedish mentality. I really do. It was almost, but it was just interesting to see that change. But so in Israel, you have the guarantee of services, the basket of services. Now, what the problem becomes financially is that you also do have private medicine in Israel. Meaning you have four health, like what we call HMOs or sick funds that they're called, health services that you can choose from, and the government did that on purpose, unlike Canada, or that they only have or England, that's a one provider system, they specifically made up for, so there would be competition, so there is a level of sort of capitalism to offer different services. Ironically, it's pretty much come down to it that each coupa, more or less, each health fund more or less offers the same added benefits. So basically what the government said, yeah, so now the government said, like, okay, guys, you're missing the point. You have to get competitive again. But so what happens is that you can pay more money a month, and then you'll get additional services. So
what's
I want to see a private coverage?
What is it? What are the kinds of things that everybody gets?
So the basic coverage is everything. I mean, it really is. It's your primary care physician. It's any surgery. Every year the government decides which medications are in the basket of services, and so you're eligible for those either free or at a very highly subsidized rate. There's a small copay for every service, but it's like, to see a specialist, it's like $10. And there's also a cap, so after a certain amount of visits, you don't have to pay anymore.
Right. Ours is exactly the opposite, literally. Right, like I have a copay that's 5 times that. It's $50 for a specialist, and I'm not covered for those until I pay my deductible. So yeah, here there's no. So what happened is that there did sort of become like this. If you had money, then either you could get the privatized sort of extra supplement plan from the sick fund, or you could pay completely privately if you had, a lot of extra money lying around, let's say. And the government did not like that because they felt that it was really creating, a two-tier system of those have and have-nots. So they restricted a great deal access to private services. And so there's a lot more sort of hurdles in place to prevent people from accessing those more easily. Interesting.
And I do understand that, but I don't really think that it was done in such a smart way. So basically, the money was supposed to go, they were supposed to take it and give a budget to the hospitals to surgeries are where you see this a lot. Because if you have an elective surgery, like a hernia can be elective surgery, a sinus, things that don't feel so elective, but are, so you could be on the waiting list for months. And so, that's why people would choose a private doctor, because then you could often get the surgery within weeks. So the government said, like, let's put more money into the hospitals so that there'll be more surgeries. That hasn't quite happened yet. But the truth is, and I tell people this.
Is there a difference between hospitals? Because that's another thing. So, are there public hospitals and private hospitals?
So there are for sure. The majority are public hospitals. There are a few private hospitals. Most of them are in Jerusalem, but the private hospitals are allowed to offer private surgeries and private consultation in the hospitals. The public ones are not. So what you will find, and which is very interesting to note, is because I deal a lot with people who come from the American system and now are integrating into the Israeli system, and in their mind, if he's private, he must be better. And I said, no, it's the same doctor. The same doctor is going to operate you, in the public hospital, and then it'll be more, faster if he's doing it privately.
Right.
Which is sort of the irony.
Well, and that's actually another one of the questions, if the level of care is the same in a public and a private facility, because it is here in theory, but you may wait longer periods of time, if you're at a public hospital, again, because of that kind of tiered, they have to prioritize, because we have very few public hospitals. Most are private, and so you have to have insurance.
Right.
Yeah. So let's talk again about I
just want to.
Oh, please.
But just to answer your question, the difference isn't so much in the public and private, but the difference you'll see in care is in the geographic periphery versus the center of the country, where the higher population and the wealthier population is. I mean, as you see in like a lot of, I spent time in South America. I lived in Argentina, and you see a lot of South America. It's the same thing, peripherals. So it's a big issue here. There've been a lot of studies on it. They lack doctors because doctors don't want to live in the periphery. You did your 6 years of medical school, and then I did my X amount of years of residency in orthopedic surgery. I don't want to live 2 hours away from I want to be in the center of things.
I spoke with somebody yesterday in Santiago, Chile, and he was talking very much about the idea that in Chile the difference between public and private is significant, and the care in public facilities is not the same level that it is in private. So what they don't have is what I think you guys do well, which is this idea that it's the same physicians working in both places. And so can you expand a little bit on that? So a doctor in Israel, how are they paid? How does it work? Who's, private, public?
So it's super important to note, and I try to explain that to people when a lot of people ask me, they said, do you think that the American system could make changes? It could switch, could it make itself more similar, let's say, to the Israeli system? And I said, you have to understand that the very payment structure, the concept of, doctors are paid a salary in Israel. They're paid a salary, plus if you work for the sick fund, like you can arrange your own contract. So there are deals to be made, but you get a base salary, and then you get, on top of that, you get paid per patient per quarter.
Okay.
So you have no incentive, like, to do a procedure, to not do a procedure, etc.
No financial.
That's in the
no financial incentive.
No financial, exactly. In the hospital. I should make a caveat for that. There are a few things that they've changed because doctors were complaining that they said, look, this procedure is going to take me 45 minutes and you're paying me the same as a visit as if it would take me 10 minutes. So there are now certain procedures that in fact, you get paid extra for. But in the hospital, it's also, the doctors are salaried. So then there's no per capita, and once you reach a certain level and you can receive people privately, then you get paid a percentage of whatever it is that you determine, but obviously you work underneath the, some kind of system.
Interesting.
And if you're doing surgeries.
So one of the other things that I've noted, having spent a lot of time in Israel, and unfortunately in the health system, the way I've always seen it is that Israel will offer the best levels and quality of care in the world because of research and the facilities that you have and the energy put towards it, but it's in not such a nice package, and it can be received very roughly. We were in Israel a number of years ago, and one of my boys had to have an emergency surgery, and what a nightmare!
Wow.
It was just.
I wish you had known me then.
You know what? A lot of my family are physicians, so that wasn't the issue. And I speak Hebrew, so that's not the issue. It doesn't matter. That's another whole conversation. But the point is that in the U.S., part of what we get for all the money that's spent is it's rare that if you're in a hospital, any hospital, that you share a room, unless you're in a public hospital. And
really?
Facilities are like a hotel sometimes. And so I think that's another big piece of it where the difference is so great from U.S. because as Americans, we're very used to not having to wait, or the expectation is that you're going to be taken care of well and provided with amenities, and moved along fairly quickly. So that kind of leads into another of the questions, which is when somebody is arranging care. So let's just say a mom needs to take their kids to the doctor for whatever reason. How does that work?
You mean on the basic level of making an appointment?
Yeah. Because I know by us, if everybody's you have a private doctor, and you have to pick that doctor based on the insurance coverage that you have, which is why many Americans who are underinsured or poor, which is probably the majority of the country, go to the emergency room for their care because they don't have
primary care.
Or an urgent care.
Yeah. This is how it was in Philadelphia when I was working there.
Yeah.
So here you have to choose a sick fund, like a health service with the HMO, as it were, and you have to choose one. And then depending on, you have to choose, depends which fund you're in and which geographic area you're in. They've become very good at digital, so all the you can make your appointment online. There's also an operator. You make the appointment and you go in, and you either pay your small fee, but the wrapping, how you get the concept of amenities and service, and it's a very different perspective here. And I think at the end of the day, this is probably also true in the States, but maybe it's like a little bit more packaged differently. But at the end of the day, you are your own case manager / moving things through. And if you are, caring for others, so then you are also their case manager, meaning I can have a great doctor, but I often have to know the questions to ask. If somebody needs to have a procedure, I need to be the one who's going to seek out a second opinion. I need to come with my questions. I need to find out, is this an overnight stay? Sometimes the information will be given to you, and then I see that as like, that's sort of an unexpected gain, but not what I'm expecting. Is that, it will fall on me to figure out, how this is going to play out and what do I have to do.
Right. Well, and interestingly, as you're mentioning this, what goes through my mind is the idea that in the U.S. there can be the added concern that is this necessary, or is there some financial gain behind it by the referring practitioner? Whereas it sounds like in Israel that's not an issue.
No, the system worked very hard to remove that concept. And what's interesting is that when I'm helping people transition from the American system to the Israeli system, it's a big issue because a lot of times people have taken medications for a long time that then they come to Israel and it's not covered because it's not a first-tier medication, because it's expensive medication. So the government says, you have to try these first and then go to that. And they said, but I've been taking it, but they never tried the first tier because in the States, it goes right often more to the expensive medication. There's like the whole referral that,
Absolutely.
I don't know enough about it at all.
Listen, we have ads for our medication.
Yes.
Our pharmaceutical companies, they know what they're doing, and they convince you that you need it even before you have a problem.
Yes, exactly. So because we have this basket of services, and people often come and they get very frustrated because they're interpreting it as they're not getting as good as care because the doctor didn't prescribe the medication, because he didn't send them right away to an MRI or a CT, whereas because here the doctor can refer all he wants, but it's up to the administration of the health fund to determine whether or not they're going to cover it, like the insurance.
Okay.
And certain things are covered without question, but other more expensive procedures like an MRI, you have to demonstrate that there is a justified reason why you need that intervention.
But isn't it the physicians who have to demonstrate that? So, for example, if I don't even know where to be. Let's say with an MRI, let's say somebody comes in with a knee issue, and the orthopedist has done other things, and they're not sure what to do. And he says, okay, we need an MRI because otherwise I'm not going to get the information that I need. Is something like that then covered? Or is there yet another level of administration of somebody else making the determination whether that'll be covered?
So first of all, yes, there is another determination by another level. It's the doctor, the special doctor who sits there who will determine whether it'll be covered or not. And basically, because it's cost prohibitive, meaning if they say no, it's not something that you can then say, oh, okay, I'll just pay out of pocket and do it anyway. They won't let you do that for most of these things. But interestingly, so first of all, there's somebody else making a decision, but more importantly, and here it comes to the communication, is that the responsibility, in a sense, de facto falls on the doctor to know how to make the request from the administration in a way that the administration will approve. And the doctor does not learn this in medical school at all.
Right.
He might never learn this.
We call it coding. And
coding, yes.
Coding.
Yeah.
And it is exactly how coverage is determined. And I don't know if it's U.S. or international. It's probably just U.S. We have the ICD-10.
Yeah, we use some of those codes. We have different codes, but yes, they use them also internationally. Yeah,
and that's how coverage is determined. And interestingly, my wife is a physician, and a number of years ago, in private practice, and she's a naturopathic physician, and so the income is not very great, but they're covered by insurance. And so I was able to do an analysis of her coding, and simply by changing the coding that she was doing, nothing else, we increased her income 30%, right? And so, but nobody teaches you that. Nobody shows you how to do it. And
but wait, her pay is connected to her coding.
Yes. So
whether it was approved or not?
No, so we call it reimbursement. Okay, so you go to a doctor and they treat you. There's no guarantee that you're going to get covered. And sometimes the insurance company says, well, this is a procedure or this is something you have to pay out of pocket for first, or at least come to a financial arrangement, and then we'll pay you back for the cost of that.
Right.
So insurance companies in the U.S. have contracts with doctors, and they say, okay, Dr. So-and-so, we're going to pay you X number of dollars per procedure or per person that you see. And then the additional, it's based on the coding. And so coding is about how complex something is, how much time it might take. But it is so complex that there are layers of the coding that most doctors who just want to see people and help them don't have that time or energy or wherewithal, frankly, to do that. And so we basically spent some time working with a coding specialist, somebody who that's what they do for work. And after 4 or 5 hours, we were able to learn enough to gain and make changes in how she applied for reimbursement, and therefore was able to increase the money she was receiving. And there's no change to the patients. From the patient perspective,
it's the same interaction.
Exactly. Yeah. So I'm always fascinated.
So here it's not. Here we don't have the specifics of the coding determines, but for sure the wording, how much information you're including, what testing you're including. So there are some doctors who get it, and there are other doctors, either they're new or they unfortunately don't care, or they also never have the feedback. You know, that they don't know that their things aren't being approved. So I've actually, I mean, some doctors are extremely appreciative when I send the patient and I say, bring this template to the doctor and tell him this is how he has to write the referral. So some are super pleased, others are offended. You know, it really depends on the...
Yeah, who are you to tell me what to do?
Yeah, even though this has nothing to do with what you learned in medical school, but it is so crucial to patient care.
Right.
You know, that, and no one's teaching it. Yeah.
So just to wrap up and out of curiosity, so you're somebody who has experience in both the American system and the Israeli system. How would you highlight the differences, and both positive and negative? Because I think that it's very clear that the grass is always greener. It always seems like other people have things that we don't. But I do appreciate and understand that there are benefits to each side. And it seems like Israel somehow has an interesting, nice mix between what I think of, or most Americans think of, as a socialized medical system and a private one.
Right. So, yes, having lived in both systems, I have to say that I feel extremely lucky to live in Israel with a healthcare system, because I see my friends and I see, unfortunately, the amount of money that they have to spend on healthcare every year. That, I have the luxury that I don't have. I mean, I have a lot that they don't have.
You mean in the...
They spend, my friends in the U.S., yes. And the few people that I that I keep in touch with over the years.
Yeah.
And I also, the feeling that I know very securely that if I'm in an emergency situation, I'm covered. I'm good. I don't have to worry about, oh no, I'm going to meet an emergency procedure and then I'm going to accrue debt, which is a very good feeling to have, also for myself and for my family. I think that's a huge plus. It's not even on the table. And I think that Israel put a lot of emphasis on that for the concept of there are more things that are important than financial gain of a country, and one of them is to be able to have a population that can have access to good quality health care. That being said, the concept of customer service, or the concept of having the person involved in the decision-making process in order to feel part of things and feel satisfied with the care they're receiving and understanding the quality of care they're receiving is a work in progress. It's for sure, I mean, I've been here almost 25 years. It's night and day to what it was when I first arrived. But and that's basically the price that you pay, I think. Like you said, that almost everybody has a private room, and, in America, that's not even on the table in Israel. I mean, we're lucky if you don't have people in the hallway,
Right.
I mean, the concept of waiting, yeah, you're going to wait. You're going to have, you're going to be seen by residents, in a lot of places, which I'm sure also is in the States. It's the same
Absolutely.
thing.
Yeah.
Yeah. So it's, you pay almost a third of your salary to, I mean, it's not all for healthcare, it's, but that's the price that you say everybody pays in, because it's socialized medicine. It's a socialist country with like a sort of weird, capitalist bent to it. Can't quite figure out where it is, but there's that aspect. We all put our money into the pool, and then, yeah, there are definitely going to be more people. I work independently for myself, so I am not eligible for a lot of the social benefits. I'm not eligible for unemployment. I'm not eligible. I don't have sick days, vacation days, a lot of the extra benefits that are guaranteed to workers I'm not eligible for. I've, now in the times of COVID, I see it even more strongly. And on the other hand, there's paid maternity leave for all that the government is paying for and not the employee. I think we've gotten so used to this concept in America that the employer and health is connected that if you think about it, it's a very weird, it's not actually intuitive.
No,
why should your
not at
employer
all.
be in any way? Yeah.
Well,
Yeah,
in the U.S., it's all
it's an historical.
financial. It is. It is. It comes from,
Yeah.
just because that's the way it was set up. But I think it's
Right.
as much this idea of a healthcare in the U.S. is a business, and that's ultimately how it's treated and guided
Right.
as a business. And in business,
Right.
when you're not making money, that's bad. And so, as long as one of the inherent challenges I see is as long as there's financial incentives to do things that are unnecessary to keep a system going or to keep somebody, employed, that's a problem in healthcare because they're incentivized then to potentially do things that aren't necessary
Right.
or aren't necessarily
Right.
good for you.
Right.
Although interestingly, your comment about the unemployment and sick days is the same here, right? The difference is that here, like myself, I work for myself. If I don't have any of those things, I also don't have health care at all. And so
Right.
I get hit by
Right.
a bus and, yes, I'll get treated at the hospital. Interestingly, if it's a private hospital and you don't have insurance and they can transfer you to a public hospital, they will. And so it's all about business here and keeping numbers up. And
Right.
yeah, it's
I
fascinating.
think that you just hit the key issue is that in Israel it would be like it's a nice to have, but it is not a business.
Right, and you actually highlighted it from a different perspective though, but we get great customer service, but we pay an exceptional amount of money for it. You guys have great medicine, but you don't have to pay. But the customer service is, so
not really.
Yeah, well, frankly, not good.
Yeah.
Yeah. Well, I think people can't even imagine. I've explained to friends here in the U.S. sometimes, a little bit of our experiences in the hospital, and it sounds like a horror movie. We were actually in Polia, in outside of Tiberias.
Oh.
Okay.
Before that's one of the hospitals I was talking about in the periphery.
Well, and today it's brand new and beautifully built, but when we were there about relatively, but when we were there about 10 years ago, it had been under construction. We were in the hallways most of the time. It felt like most of our time was spent fighting with all the nurses and the doctors and this and that, and who aren't sharing any information, and that's what we're used to getting. We're used to being told, here's why we're going to do this. So yeah, it's fascinating. So listen, thank you, and I really appreciate it. This is always fascinating to me to see these differences, and I think that down the road I'm going to explore some other questions as well, because I do think that this focus of just kind of comparing the system that we have here to what exists around the world is an interesting one that people appreciate. So
no, it's very interesting.
Yeah,
we will continue our dialogue.
Absolutely, yeah.
After this forum.
Yeah, we're just going to end it right here. So thank you again, Aviva, and I appreciate the time.